Back, the chair recognizes Dr. Joyce from Pennsylvania for 5 minutes.
Thank you, Mr. Chairman. At this point, I ask unanimous consent to enter into the record a statement from the American Academy of Dermatology in support of H.R. 2474. Thank you for being here today. Your impact and your discussion allows us to have better impact as we continue to legislate and look at the burdensome costs that occur with Medicare, but the inadequate reimbursement that occurs to so many physicians throughout America. As a doctor who has practiced in rural Pennsylvania, I witnessed firsthand many of the unique barriers to care affecting our rural and ultimately our underserved communities. Today in the United States, unmet demand in rural areas for my subspecialty dermatology is on the rise and not projected to improve. In fact, HSA estimates 39% adequacy in non-metro areas for dermatologists in the short time frame by 2035. This raises the unfortunate question of what happens to Americans who don't have access to care. One of the greatest threats to physician access in rural and underserved areas is arbitrary annual cuts to reimbursement for Medicare physician services. Declining reimbursement rates, especially those supported by rigid bureaucratic whims and not actual data, are discouraging doctors from treating Medicare patients. Let me say that again. That annual decrease in costs discourages doctors from taking on Medicare patients. If fewer doctors are available to treat Medicare patients in already underserved areas, then there will be fewer opportunities for preventative screenings, leading to delayed diagnosis, and ultimately more cancer patients for you to see, Dr. Pat. Dr. Pat, you as a physician, can you tell me how the decrease in Medicare reimbursement impacts your practice and the patients that you see?
Thank you. So we published, so myself, I was a lead author with Dr. Lucio Gordon and other members of the Community Oncology Alliance during COVID, a decrease in cancer screening substantially down because of the pandemic. And even coming out of the pandemic, we recognize that people have had competing priorities as they engage with healthcare. There are fewer doctors to see people because reimbursement is down. It is more difficult for people to get the care that they need that they've delayed during the pandemic because availability is less and demand simply outstrips supply. This leads to difficulty in getting in to see the doctor. This leads to difficulty when you find a breast mass of getting a diagnostic mammogram. This leads to a difficulty in getting a colonoscopy if you have bleeding. So these natural consequences of this pent-up demand and decreased reimbursement is that there are delays in patients getting care. I observe that when patients present with their cancer, when they present with a stage 3C breast cancer, because they knew they had a breast mass, but it was difficult for them to manage getting care. And then their cancer is much harder to cure. So this has been a tremendous burden, and it's certainly been exacerbated by the pandemic. But a root cause is the declining reimbursement, that it's not allowed us to scale capacity of medical services and staff to meet the demand that we have.
Thank you. I also believe that this current trend should be unsustainable, but it's going to yield to decreased access and worse healthcare outcomes, as you just delineated. Mr. Albanese, in your testimony, you acknowledged the need to offset any increases in physician payments with savings from other areas of Medicare Part B. Site-neutral payments for services has been one proposal that has received a lot of attention at this committee, and so has reform of the 340B program. Could you please elaborate as to how these ideas could be advanced by this committee without exacerbating financial pressure, particularly on rural hospitals and the rural patients that they serve?
Thank you, Congressman. I certainly would echo what others on the panel have also said about site-neutral payments and reducing the disparity between payments for hospitals and physicians on numerous services such as drug administration, imaging, and clinic visits, to name a few. With regards to 340B, this is a discount program where hospitals have been able to achieve 25 to 50% in savings. and they are not required to pass these savings along to their patients. So, whereas Medicare is required to pay the same amount for these drugs as for other drugs. So I think Congress requiring, or at least giving CMS the authority to pay more accurate rates for these drugs would yield huge savings for taxpayers and for patients.
Thank you, Mr. Albanese, for your response. And again, thank you for your witnesses for what has turned out to be a long day. Mr. Chairman, I yield.
Thank you. The gentleman